Coming to stage 3B, here we see macroscopic peritoneal metastasis that is beyond the pelvis, okay, that is up to 2 cm in greatest dimensions. There can be plus or minus retroperitoneal lymph node involvement. Clear? Next is stage 3C. Here also you have a macroscopic lesion which is more than 2 cm in greatest dimension. This is less than 2 cm. Which one? 3B. Whereas 3C means it is more than 2 cm in greatest dimension without metastasis to the peritoneal lymph nodes, and this includes extension of tumor to the capsule of liver and spleen without parenchymal involvement of either organ. Okay, so 3C is important in that way. So 3C, whenever you see cancer involvement of the capsule of liver or spleen, then it will be coming under 3C. Okay, not the parenchymal involvement. Parenchymal involvement means it will be coming under stage 4. Okay, so that is 3C. Then coming to stage 4, you have pleural effusion with positive cytology, that is 4A, and 4B means it is parenchymal metastasis and metastasis to extra-abdominal organs. Extra-abdominal organ means it can be inguinal lymph nodes and lymph nodes outside of the abdominal cavity. Okay, so one day retroperitoneal lymph node involvement will be kept under stage 3. Even inguinal lymph node staging is brought under stage 4B. Clear? So this is all about ovarian cancer staging. Now let's see about grading. So grading is also important because this is something you can correlate with the prognosis of the carcinoma. Okay, this grading system is only for the epithelial tumors of ovary. Okay, and for the non-epithelial tumors we are not applying it. Okay, that is one thing. And another point is that we have a separate grading system for serous adenocarcinomas and the non-serous adenocarcinomas. Okay, first let us see the grading system of serous carcinoma. So, I told you this is the most common tumor, right? This is the most common tumor in both the ovary and the fallopian tube, and it is going to make more than 90% of the fallopian tube carcinomas also. And these tumors are going to make more than 90% of the fallopian tube carcinomas also. Okay, so they are classified into 2 grades. One is low grade serous carcinoma and the next one is high grade serous carcinoma. Okay, low grade and high grade serous carcinoma. Okay, let's see about low grade tumor first. So low grade tumor means they are often associated with borderline or any atypical proliferation like that, and they usually have any mutation that is associated with BRAF, KRAS, and they also contain wild type TP53. Okay, and if you take the high risk type of epithelial cancer, so these tumors are classic appearing and they contain high frequency mutations of TP53. Okay, so that is all about serous carcinoma grading. Okay, when we speak about the non-serous carcinoma of epithelial tumors, that is nothing but your endometrioid, which is the second most common type of epithelial tumor, and also the mucinous tumor. Okay, so this grading is similar to that of uterus cancer grading, and it is based on the architecture with one step upgrade if there is any prominent atypia is seen. Okay, so these are GX, that is the grade cannot be assessed. G1 is a well differentiated tumor, G2 is a moderately differentiated tumor, and G3 is a poorly differentiated tumor. That's it. Clear? Now let's see about the primary peritoneal cancer. Okay, we have to know one thing, peritoneal cancers are indistinguishable from the ovarian cancers or the fallopian tube cancers by histology. Okay, of the types described, epithelial cancers will constitute about at least 15% of them will arise from peritoneum. Okay, that is peritoneal lining of the pelvis or the abdomen. And you have to know that these tumors can arise many years after bilateral salpingo-oophorectomy, and histologically speaking, peritoneal carcinomas are mostly papillary serous carcinoma, okay, that can be moderately to poorly differentiated, okay, and clinical behavior, staging, treatment and prognosis will be mostly like a epithelial ovarian cancer. Clear? Right. Now, let's talk about fallopian tube cancer. It is usually believed that only 0.3% of gynecological cancers are seen arising from the fallopian tube. I already told you that many high-grade serous carcinomas of the peritoneum or the ovary has been arising from the fimbrial end of tube. But not all of this has been designated the correct site of origin, right? So, the real incidence of fallopian tube cancer is unknown. Okay, it must be probably high than what they have calculated till now, right? So, fallopian tube cancer can be primary, which is more common, or it can be secondary also, where the site of origin can be ovary or endometrium or even gastrointestinal tract or even breast. Clear? So, what we have to do is, you should see a macroscopic growth of the fallopian tube or the fimbria to make it as a primary tubal cancer, and you should also make sure that ovary and the uterus are free from any tumor. If present also, they should be clearly distinguishable. Clear? And then mostly epithelial tumors are seen and they are much serious condition also. But however, staging, risk factor, prognosis and treatment are all going to be like a epithelial ovarian cancer. Clear? Now, let's also discuss about the route of spread. Okay. So, route of spread of tumor. First one, ovarian epithelial cancers spread by exfoliation of cells into the peritoneal cavity. Okay, so this is one route. Also spread by lymphatic route and hematogenous route are also possible. Clear? Now, let's see what is this transcoelomic spread, that is the exfoliation. See, this is the most common mode of spread. What is basically happening is there is exfoliation of the cells from the ovarian surface and it is going to implant on the peritoneal cavity. Now, the cells that are implanted in the peritoneal cavity are going to follow the circulation, that is peritoneal circulation, and it is going to implant in various sites like the liver or posterior cul-de-sac or anywhere in the abdomen or pelvis, right? So, that is what is going to happen. So, what is happening is there is exfoliation of cells which are going to implant on the peritoneum surface. Now, these cells tend to follow the circulatory path of peritoneal fluid and metastasis happens. Okay, metastasis can happen anywhere. Okay, it can happen in the posterior cul-de-sac or paracolic gutters, right side hemidiaphragm, even the liver capsule, okay, the peritoneal surface of the intestines, mesenteries, and even in the omentum. Okay, sometimes what happens, the disease will involve the bowel and it will agglutinate the bowel. Okay, agglutinate the bowel so that there is progressive intestinal lumen obstruction. So, that will be resulting in a condition called as carcinomatous ileus. That is nothing but a functional bowel obstruction. Okay, this is a functional bowel obstruction that is caused by the exfoliated cells. Clear? Next spread is lymphatic spread. So, lymphatic spread can happen to the pelvic or para-aortic lymph nodes, and it happens particularly in advanced stage. Okay, spread to the lymphatic channels will be going to the diaphragm and it can go to the retroperitoneal lymph nodes. Okay, diaphragm means the lymphatic channels, the diaphragm will be involved. Okay, then even sometimes above the diaphragm the spread can happen. That's why we are checking supraclavicular node involvement during examination of the patient with carcinoma ovary. Okay, left supraclavicular node involvement. Clear? Coming to the next one, that is amatogenous spread. So, this is one uncommon spread, but it is the most common cause for distant metastasis to lung, liver, bone, subcutaneous tissues as well as pericardium also in some rare cases. Clear? Now, let's see the management of ovarian carcinoma, and primarily the staging and management of ovarian carcinoma is going to be surgical. Okay, so management. The procedure is staging, laparotomy. Okay, so a staging laparotomy is important for early stage management. If there is no visible or palpable metastasis, a thorough staging laparotomy is a must for early stage management of the carcinoma. But if you don't find any palpable or visible lesions upon opening the abdomen, then the following should be done in order to obtain a proper staging first. Okay. So the first one is you have to carefully evaluate the peritoneal surfaces. Second one, there should be retrieval of any ascites or peritoneal fluid. Okay, suppose if this is not present, means you have to give a peritoneal washing, okay, with normal saline, and then you can obtain the fluid. You have to do an intrapolic omentectomy. That should be followed by selective lymphadenectomy of your pelvic and para-aortic lymph nodes. Okay, pelvic or para-aortic lymph nodes, and this will be done unilateral if the tumor is unilateral. Then if you find any suspicious lesions, then you will go for a biopsy or even the resection of that particular lesion. It may be a mass or a adhesion also. Okay, and not only this, you can even go for any random peritoneal biopsies that can be taken from the cul-de-sac or the hemidiaphragm, okay, especially the right hemidiaphragm, and even from the bladder reflection or the right and left paracolic recess. It's not all, we are going to take specimen from all of these things. Okay, and after this, definitely in most of the cases you will be proceeding with total abdominal hysterectomy with bilateral salpingo-oophorectomy. And if you find any mucinous tumors, don't ever forget to do, yes, what is it? Very good, it is appendicectomy. Appendicectomy should be done, right? And after this, and don't forget one more thing, you have to check whether any capsule rupture is present or not. Okay, so that will give you a proper staging. Fine, right? So in younger women, suppose the woman is a young female, then fertility will be a bigger issue, right? So in that, there can be a need to preserve ovaries and preserve any one-side ovary, tubes and ovaries. So you perform unilateral salpingo-oophorectomy. Okay, and sometimes the problem in these females will be whether you have to offer them a laparoscopy or laparoscopy. Okay, suppose if the clinical suspicion of for malignancy is high, then you can directly offer them laparotomy. Okay, suppose if she is a young female and the clinical suspicion is more for a benign disease and the tumor markers like HCG, AFP, okay, so all these things are normal, means definitely you can offer them laparoscopy. Okay, but anyhow, even if you do laparoscopy, a frozen section of the specimen should be performed, as well as any other suspicious lesion has to be taken for biopsy. Clear? Now coming to the management of epithelial ovarian cancer. Okay, we are going to study about the management of epithelial ovarian cancer. So, now for stage 1A and 1B, stage 1A and stage 1B, and when they are of grades 1 and 2, okay, grade 1 and 2, we usually offer total abdominal hysterectomy with bilateral salpingo-oophorectomy along with intracolic omentectomy. Okay, and I already told you this can be converted as a USO for a female who is willing to preserve her fertility, right? And keep in mind that only surgical treatment is enough in this stage. Okay, that's why I specially mentioned it, and there is no need for chemotherapy in these patients. Clear? Right. Now, the next set of stages we are going to discuss is stage 1A, 1B, where they are of grade 3, that is high grade tumor, or stage 1C or stage 2. Okay, so in all the stages what you will do is you will give 3 to 6 cycles of chemotherapy. Okay, obviously yes, surgery we are going to perform. Okay, surgery will be performed. You have to do all the staging laparotomy as I said, but that will be followed by 3 to 6 cycles of chemotherapy. Okay, and how you will follow up these patients? For follow up, the patient should be called once in 3 months for 2 years, then once in 6 months for 3 years, and finally she should be called annually. So what will you offer when patient is coming? You have to offer her a complete physical examination. Second one, a pelvic examination. Even if you offer chemotherapy after surgery, 20% of the patients can be seen with recurrence within 5 years. Okay. Now, let's discuss about the management of advanced ovarian cancer. This will include primary debulking surgery. Debulking surgery is nothing but you proceed on with total abdominal hysterectomy with bilateral salpingo-oophorectomy first. Then you will perform an omentectomy, followed by there will be a surgical cytoreduction. Okay, that means none of the tumor that will be left over after debulking maximum possible lesions or any mass or any kind of lesions that is susceptible. Okay, following that there will be surgical cytoreduction. Cytoreduction means any suspicious lesion will be removed when you see it. Okay, so that the leftover tumor mass, if present, it shouldn't be more than 2 cm at all. Okay, there is also another term. That is optimal debulking. That means individual residual tumor size is less than 1 centimeter. Okay, and this procedure may also need additional surgeries like splenectomy, large or small bowel resection, or appendicectomy, exit. Okay, even systemic lymphadenectomy can be done. Clear? Next one is chemotherapy. So the routes of offering chemotherapy are intravenous or intraperitoneal, We can give IV chemotherapy by giving 6 cycles of the following combination of drugs. We choose platin group of drugs, either Carboplatin or cisplatin, that will be combined with taxane group of drugs, that is Paclitaxel or docetaxel. Okay. Next one is intraperitoneal chemotherapy. So this is mostly given for stage 3 patients after you do optimal debulking. So what is optimal debulking? Just now we saw, yes, less than 1 centimeter tumor size only should be left. Okay. And what is the concept here is, the epithelial tumor spreads mostly along the peritoneal surfaces. Now we have two types of intraperitoneal chemotherapy. First one is HIPEC, which is hyperthermic intraperitoneal chemotherapy. See, here we will be using concentrated and heated chemotherapy. Okay, so the commonly used drug we have seen is, say, cisplatin. So this will be heated and concentrated, and this will be given directly over the abdomen during surgery. Okay, directly to the abdomen during surgery. Okay, so this is hyperthermic intraperitoneal chemotherapy. Next one is PPAC. This is nothing but pressurized intraperitoneal aerosol therapy. So this is mostly given as a palliative treatment. Just the name is alone enough for you. Okay, I am not going into the details. Okay. There is something called as targeted therapy. Here we identify and attack the cancer cells itself. Okay, and we should take care that there is minimal damage to the normal cells. Clear? So what are the drugs used here? We have angiogenesis inhibitors like bevacizumab. Also PARP inhibitors. What is PARP? Yes, poly ADP ribose polymerase inhibitors. Okay, so these drugs will include olaparib and rucaparib. Okay, mainly the PARP inhibitors are given in recurrence as well as when they are present with BRCA mutations. Is that clear? Right. Now, there is something called as interval debulking surgery. Okay, interval debulking surgery. In interval debulking surgery, first we will offer neoadjuvant chemotherapy. Chemotherapy which is given prior to surgery is neoadjuvant chemotherapy, right? So, first we will give neoadjuvant chemotherapy say for some 3 to 4 courses. Then we will do the surgery, that is interval debulking. Okay, why it is called as interval? Because we are taking some time to decide on the surgery. Okay, we are waiting to give the chemo cycles to be covered, right? Yes. Then we will proceed with post-op chemotherapy as well, that is 3 courses. So the 6 cycles of chemotherapy is divided into 3 and 3. 3 will be neoadjuvant chemotherapy and the other 3 will be post-op chemotherapy. Clear? Right. Now, what are the indications of doing this interval debulking surgery? Indications will include if she has any comorbidities or ascites, metastasis or pleural effusion. Clear? Now, let's also talk about recurrent ovarian cancer, because recurrence is not so uncommon with ovarian cancers. Okay, so we can classify recurrent ovarian cancer into 3 types. First type is platinum refractory type. Okay, what is platinum refractory type means? The tumor is progressing even during treatment. Clear? The next one is platinum resistant type. That means the relapse is seen within 6 months. Fine. And the next one is platinum sensitive type. Okay. Here also the relapse will occur, but the relapse occurs after 6 months, 6 to 12 months also. Okay. After treatment. So what will you do as a treatment part? What will you do when the relapse is happening? For the first 2 types, you should know the prognosis is worse. Okay, you can try non-platinum chemo. Okay, that's it. Whereas for the platinum sensitive type, you can do secondary cytoreductive surgery. Okay, secondary cytoreductive surgery. Clear? So this is all about recurrent ovarian cancer. Done? Yes. So with this we'll be finishing part 1 of carcinoma ovary discussion, and we'll meet in the next part where we'll be discussing about the germ cell tumors and the sex spots, common cell tumors. Keep going, happy learning, take care and bye bye.